work its way up. Soon it's hard to breathe if you know anyone who's had congestive heart failure and episodes of that. Very difficult for them to breathe because now it's backed up into the lungs, right? So not a good problem to have. Many times they can't even lay back slightly. They have to literally sit up and they're still having very difficult time breathing. They're basically drowning alive, okay? Because of this fluid overload. So that's not a good thing to have. People will get like the puffy faces and all that stuff, or the arms will get have fluid overload as well. So you can have it in different areas, but ultimately in congestive heart failure, first of all, congested, right? Fluid overload, and because your heart is failing you, it's not working the way it's supposed to, and the kidneys can play into that. They have roles with it. Elevated weights such as urea, creatinine, which is your muscle breakdown, and potassium, right? Electrolytes. That's huge too. And then changes in hormone levels that regulate your blood pressure. The biggest one for that, we're gonna discuss over here in a second. Making red blood cells, right? Like we talked about the EPO or erythropoietin. And then uptake of calcium, right? Because we said it activates vitamin D. If you have no calcium, you can't activate vitamin D. Those two go hand in hand. Okay, so really your kidneys do a lot. I mean, this is like just the basics. Your kidneys do a lot for you, so we gotta treat them well. Decrease in any Coke products helps your kidneys out. Making sure you're drinking enough water throughout the day. Make sure that your urine is not concentrated, right? Because then your body's saying, hey, I need more water. Different things like that. You can really, really help your kidneys out. Now, it talked about in that video that we have 1 million nephrons in each kidney. So we have 2 million overall. That's what we're technically born with. And those 1 million subunits is this. You have your glomerulus, okay? So that's where you have the artery that comes in there with the blood. It gets filtered. And the way it gets filtered is that it goes through all these little tubules. The reason it's going to be important to know this is because this is where our diuretics work. A diuretic is a medication. People call it like water pills, right? It makes you urinate a lot. So in a person who has congestive heart failure that has all this fluid retained, what would you want to do for them? Yeah, help them get rid of it, right? And so the way we get rid of fluid, excess fluid in the body, is our kidneys. Those are our filters, right? That's why when we talked about pharmacodynamics, that was the biggest one for excretion. Does that make sense, how it's kind of coming full circle?
Would diuretics also help with like pedal edema or edema?
Yes, yeah, it can. So, different diuretics work on different areas of these tubules. And so that's where we either will use it for a person or not. We'll get into that in a second, okay? But it ends up going through these tubules. At every little place, it has a sensor for everything. Water, it has different sensors throughout for potassium, sodium, magnesium, and it's basically almost like a, what do you call those? When you go to stadiums and stuff, the metal detectors, right? It's almost like that, and it's like detecting for certain things, like, oh, okay, there's enough of this, or you can pass through, okay, we don't have enough, so go back. That's basically what all these tubules and this glomerulus is doing for us with all of those fluids and electrolytes, okay? So here, it'll tell us like, oh, you don't have enough water, so over here in the collecting duct, it'll say, hey, you need to go back in line, right? Go back inside. Or, hey, I have too much over here, so let them out. And then this ends up going out to excretion through your ureters, your bladder. Okay, so there's different areas in which it works. So, again, things that we are modifiable would be limiting your caffeine, limiting your, which, Coke products are a big one for that. And also your nephrotoxic drugs, okay? So, nephrotoxic, nephron, kidney, toxic to your kidney. So a huge one of these is what we refer to as an aminoglycoside. Mean to your kidneys, that's the easy way to remember that. Okay, so your mycins, I'm sure everybody in here has taken a mycin antibiotic at some point in your life. gentamicin, there's a bunch of mycins. And those are aminoglycosides, so if you're gonna be on it for a short, quick second, and you're a healthy person, then it may not be very nephrotoxic to you. But if someone already has kidney disease, would this be something you want to give, or you try not to give? Try not to give, right? We also have ACE inhibitors, and we're gonna get into that, over here in a second too. And those are also nephrotoxic. And I know everyone's gonna ask me questions once we go over this. But those can also be nephrotoxic. Guess what? NSAIDs. Nephrotoxic, so you thought it was just your GI system, right? But if you're on it for a long time, or you're giving yourself way too much, right, over the counter, now you're like, dang, I just jammed up my kidneys too, so I'm gonna bleed out, I'm never gonna be able to pee again, like, what am I gonna do, right? So NSAIDs play a really, really big role in that. You have all these other ones, those are cancer meds, obviously that screws up everything. And then, IV contrast for any like CT scans, any diagnostic scans that you have, especially if you have diabetes, this is extremely, extremely toxic to the kidneys. So many times they'll give you what we refer to as a bolus, or basically a liter through your IV after that, to try to dilute it, so that when it goes to your kidneys, it's not that big of a deal, but guess what, you're still overworking your kidneys, right? Cause A, it needs to get that dye out, B, you just given it more fluid, so it's like, hey, really, I already do enough here. So, IV contrast is a huge, huge nephrotoxic drug. So how do you prevent it? You wanna test for kidney function, okay? Your hydration status, obviously. Educate on NSAIDs, which is what I've been trying to do through this whole pharmacology class for you guys, okay? Monitor the patient for any changes and keep those kidneys happy, right? So these are the things that you're gonna be doing if your patient is on any of these. NSAIDs preferably long-term, obviously, and not just over the counter, you'll be monitoring that. But many times that's why they'll say, hey, you need to do labs, and then we'll see whether you can take this medication or not.
Oh, is that part of the testing the kidney function? I was gonna ask, how do you do that?
That labs, yeah. We'll draw labs and see how your kidneys are doing. If they're doing poor already, then we try to stay away from these, but again, risk versus benefit, right? So if at some point it's like, I need this medication, then we're just gonna be monitoring you. And that's gonna be major education that we have to do for the patient to say, hey, if you have any of these signs and symptoms, you call us immediately, right? Or you come in. So we wanna make sure that they're definitely hydrated, right? Cause that'll dilute the medication a little bit so that it's not so harsh when it's coming out of your kidneys. Does that make sense? Any questions? No? Okay. So renal failure, how do we know when you're in renal failure, right? So we have acute and we have chronic renal failure. For chronic renal failure, it occurs normally, we say acute is 0 to about 3 to 6 months. After 6 months, for sure, you're in chronic, okay? So, chronic renal failure will occur over months to years. It can occur really slowly, it can occur really fast. Every person is totally different. Whether they have several of those risk factors, right, genetics, all of that will play into how fast or how slow they'll progress. Over half of our patients with chronic renal failure have hypertension. So is that gonna help your kidneys? No, right? So treatment, again, dietary restrictions. And what do we wanna restrict? Protein, right? Cause the breakdown of protein, or muscle ends up going through our kidneys and it can cause that rhabdomyolysis, right? That Coca-Cola P. Sodium, reduce your sodium for sure, right? Cause that also decreases your fluid overload. Where salt is, water goes, right? Potassium, phosphate, and magnesium. We have to be really careful with those. End-stage renal disease, or ESRD, end-stage renal disease. Like I mentioned a little before, you'll require dialysis and a kidney transplant. Okay, you can't really come back from that once it's chronic. Acute renal failure, you can come back from. Chronic, you can't.
You said acute is from what time?
Normally like 3 months max. You'd have to catch it really early for it not to turn into chronic though.
Are the levels for each one, are they all preferences, like when they say, hey, if you have this level in your blood, you're 1, 2, 3, 4, 5?
Yeah, it all depends on your GFR, your glomerular filtration rate.
But is it like universal? Like if
For the most part, yeah, at least nationally.
Okay.
I don't know about other countries, but at least nationally, we know where you are based on your GFR. And that's a lab that they'll take. Okay, so major role is excretion of drugs, like we dug into the first day of class, right? So this patient, right, if we say we need to modify some pharmacokinetics, we might have to give smaller doses of the drug, right? Remember that, route frequency, you guys are like, I wanna go way back there, come on lady, we're past that. And monitor the side effects really closely, cause they're at increased risk of getting to that toxic level, right? So we have to be really, really careful with that, okay? Any questions on that so far? So these are complications. A lot of our patients that go into renal failure have anemia, and that's caused by that decrease of release of the erythropoietin, okay? That's released from your kidneys. So if your kidneys aren't working and you're in renal failure, is it gonna release erythropoietin? Not that much. So most of the time they need to get shots of erythropoietin weekly, and it's referred to as Epigen. They might, they're at increased risk for hyperkalemia or high potassium, because their kidneys end up not excreting it. So we say low potassium diet is key first. Please God, let this be the last thing. K-Exolate basically gives you horrible, horrible diarrhea, and you excrete potassium that way because it's an acid. Comes out your ass. That's how you remember that. Okay. Hyperphosphatemia, you have high phosphate, also not excreting, so low phosphate diet, or you can give them phosphate binders that releases it through your GI system. Hypervolemia, that's the fluid overload, right? So the kidneys aren't excreting sodium and water, so what do? Again, if you notice, diet. Low sodium diet, most of the time if they're on what we refer to as a cardiac diet, they're on 2 grams of sodium or less a day. To give you the perspective of that, I believe that's equivalent to 1 salt packet a day. Everyone's like, really? I eat that like on one french fry, right? So imagine how much salt you're really intaking and how much you're killing your kidneys actually, okay? We can also give them loop diuretics. Again, that's a particular diuretic in that section and we'll go over that, or a thiazide diuretic. Hypocalcemia, they normally tend to have low calcium, okay? And then, if not, you'll have to supplement them with calcium. If you supplement with calcium, you also supplement with vitamin D. And then, this is acidosis, this is an acid thing, so we're not gonna get into that today. Okay? Yeah, calcium and vitamin D go hand in hand. Most of the time, if you go to like the supplement like GNC or whatever, they'll have them together when you take it in the little capsules or whatever. So diuretics, P. That's what we're talking about, increased urination, P, okay? So there's different types. So what we use them for is excess fluid, right? Because if we want you to pee, that means you have too much in your body. So hypertension is one reason. We want to pull off some of the fluid so there's not as much pressure in the tubes, right? In our blood vessels. So we'll give you a diuretic for that if diet, exercise, all that stuff is not working, okay? Most people are non-compliant, just taking a pill instead of changing the way they eat, right? Most people will do that. So hypertension, renal failure for sure, because guess what? Their kidneys just can't do it. They're not releasing, right? Does anyone know anyone with kidney failure or dialysis or anything like that, right? They blow up like a balloon. Their water retention is really bad. Again, their kidneys are not working. So the kidney's main job is for excretion, it's not doing that. So everything it would normally excrete, you have increase of waste products in your body, which is no good, right? Increase of water retention, which is no good. you're supposed to let that out. So all of that is happening in renal failure, the complete opposite of what your kidneys are supposed to be doing. So we will give a diuretic for that, to try to help them. There are times when, you can give them all you want, and it's just not gonna work anymore, their kidneys are that far gone. Liver failure is the same thing, that has to do with albumin, I'm not gonna get into that, and that leads to ascites. Ascites is what we refer to as, third spacing, so fluid gets into a space where it's not normally found. A lot of these patients look like they're pregnant, males and females. Their, stomach and things like that are rock hard, and they end up having to put a needle in there and aspirate all the fluid out, because it's not in a place where, water exchange is normally supposed to happen. Almost like saying if it got into like your knee joint, like water's not supposed to be there, right? But it happens in the abdomen.
Sorry, you said ascites
Ascites.
is when fluid builds up where it's not, like into cavities, it's not supposed to be.
Correct. Ascites specifically is in the abdomen.
Oh, it's only for the stomach?
Ascites is the abdomen, yeah. And that's the classic sign of liver failure, classic sign. And then like we talked, right, pulmonary edema. So you have all this fluid in your lungs. So in essence, we use it for fluid overload, okay? It can happen in any one of these places, but fluid overload, that's what we use diuretics for. If you are dehydrated, should I give you a diuretic? No, I'm gonna kill you. Okay, it happens. So the question is, how do these medications or how do diuretics work that they increase the production of urine? So the goal is to reverse that normal fluid retention of the body, right? All of these things are not normal things for healthy people, correct? So there's three groups. There's loop diuretics, thiazide diuretics, and potassium sparing diuretics. Okay? So again, we're gonna see these tubules over and over again when we talk about diuretics. You don't have to memorize this. However, loop diuretics are your biggest, do I have a thing on there? Okay. The biggest one you're gonna see is Lasix or furosemide. This definitely is a medication you will see all day long in your nursing career. What does it do? It prevents reabsorption of sodium. Would that help reduce fluid overload in my body? Yeah, right, because wherever sodium goes, water goes. So if I get it out of my body, water leaves too. And chloride, right? Those two are married to each other. And this happens in the loop of Henle, which is right here. This big old loop right here is the loop of Henle. You'll need to know that later for nursing, but not here. Oh, so what it does, it increases excretion of water, potassium, mag, chloride, and sodium, right? So it increases getting rid of all of these things. It's not very selective. It's just a general, like, here we go, let's wash it out. Big problem with that is potassium. We need potassium, right? Cardiac function. Huge thing for cardiac function. So if we're taking this loop diuretic and everything's going with it, including our potassium, we're at risk for some cardiovascular issues. We can get, first of all, hypotension, because now we don't have as much fluid in our cardiovascular system, right? Which decreases the pressure. Dry mouth, excessive urination, obviously, right? Anything that works too good is a side effect. Electrolyte abnormalities, I mean, look at all that. Dehydration. And the biggest thing for this medication to know is what we refer to as tinnitus. That's that ringing in the ears. When you give this medication, if you give it too quickly, especially what we refer to as IV, if you give it too quickly, you can actually cause permanent hearing loss to the patient. Happens a lot. So what we would want to monitor, obviously, labs, right, and the patient's weight, because if they're losing too much or gaining too much, we know that we either need to change the dosage on the medication. Is the patient taking other hypertension meds, right? Because if they're taking another type of blood pressure medication to lower it, and then they're also taking this, I've just given you two medications that work in different ways but end up doing the same thing, right? Is that good? No. Not unless you really, really need it, okay? So we're gonna monitor their blood pressure with this medication, and then we're also going to encourage potassium in their diet, because it helps get rid of it, we need to increase it in their diet. So then we'll say, hey, eat bananas, eat, things high in potassium. The next one is referred to as hydrochlorothiazide or a thiazide diuretic. This one's more specific, it blocks sodium reabsorption in the distal tubule. So if you see here in the distal tubule, that's where our thiazides work, okay? Okay, so it blocks sodium reabsorption. So that's, if you're basically having a problem with that and just a little bit of fluid overload, this would be a good medication for you to take, right? If your CHF, congestive heart failure is just starting, this would be a good one. Side effects, obviously, electrolyte imbalance, dehydration, and gout. Now it says hypokalemia, right? Because does this do anything to the potassium? Is it reabsorbing it in any way? No, it's just saying goodbye to it. So it can cause hypokalemia just like the other one. So we would tell them to eat things that are high in potassium, right? Bananas instead. Contraindications, you never ever give this medication with digoxin, NSAIDs, or if they have an allergy, a sulfa allergy, sulfonamides, you'll never ever give them with those. But just know this one's mechanism of action for sure, sodium reabsorption. And then we have potassium sparing diuretics, right? The two diuretics we just talked about, what happens with potassium? Stays or leaves? Leaves, right? So we have to replace through our diet. With this one, that doesn't happen. It's aldactone or spironolactone. This is also very, very common. So it inhibits aldosterone secretion, which is another hormone, and increases sodium and water excretion, and retains potassium. So this one is, like it says, potassium sparing. So would I advise this person to increase their potassium intake and eat bananas and things? No. They'll go off the other side of the cardiac spectrum and get all sorts of lethal dysrhythmias. Okay, so if they have mild hypertension, edema related to kidney or liver disease, then we'll give this to them. It's better to take it with food. NSAIDs, not NSAIDs, I don't know what it is. And digoxin, you don't give it with that. So if you can have possible hyperkalemia, right? Because it's on the other side of the spectrum. It retains it. Impotence, that's everyone's favorite. And then menstrual irregularities. Depending on what that is, I may or may not want it, right? I'm like, what? 1 period a year? Hell yeah. Sign me up. They're like, no, every 2 weeks, just kidding. So, those are your diuretics, okay? I'm not gonna get into these, so just bypass this slide. Just don't worry about those. Okay. Take a 10-minute, come back at 15. Oh wait, what time? Is that one's not ready yet?
4:07.
4:07? So come back at 20. 4:20.